It gives me a great honor to be here. I'm very humbled to present in front of the families that I've met over the last 7 to 8 years working with the EB population. I have to tell you that one of the things that I've learned from this group of patients and families is perseverance, endurance, and probably the most is love for family. In fact, I think some of these principles have been so important that I brought my family here to witness and meet some of you all. So if you do see us in the hotel, please stop us and say hi. I'm from Cincinnati Children's Hospital. I'm one of the ears, nose, and throat doctors. And I've had the privilege, as I mentioned, with working with some of the children with EB, along with the rest of the physicians in our EB center. And I wanted to talk to you about some of the ailments that children with EB have in regards to the ears, nose, and throat. I'm glad there are people like Dr. Tolar, by the way, who are incredibly smart, incredibly bright, and incredibly passionate about curing the disease. I think at most what I'm able to do in my clinic, in our EB clinic, is to help these kids feel a little bit better, to make sure that there's no problems associated with their EB disease that we can't cure. And we're learning how to do this better and better every day. And I wish I had some of the same mighty research goals that Dr. Tolar and other people in this organization have. I think with that kind of passion, there will be a cure for this disease soon. So starting with the ears, as I mentioned, I'm an ears, nose, and throat doctor. And so some of the issues that we do see with EB in children with EB is blisters, crusting, erosions, and infections of their ear canal, their outer ear, and even the middle ear. Ear disease is common in all kids, and it's one of the things that should not be ignored in kids with EB especially. And so it's important with these kids, and what we do in our clinic is to make sure that the ears are taken care of from a wound standpoint. So whether that mean antibiotic ointments, emollients to keep the wounds healed and the crusts to a minimal. It's to make sure that the ear canal is nice, wide, and open so that we can see the eardrum. And this is a picture right here of what the ear canal and the eardrum look like. So if you're looking out, and what we use is something fancy called the otoscope, and we look right into this ear canal, we see the eardrum, and what we're interested in is not only this ear canal, we're also interested in this eardrum and what's behind the eardrum. And in some kids with EB, because of the skin disease, and also because of some wax buildup, it's hard to see this eardrum. So it's important that as these kids go to their doctors, as these kids go to their ENT doctors, that the ear canal is cleaned out, that the doctor can clearly see the eardrum and diagnose any kind of middle ear diseases. Kids with chronic recurrent ear infections, or kids who build up fluid behind their eardrum, back in this space back here, we often put ear tubes in, and that I don't think is an exception for kids with EB as well. You get the fluid off, you keep the hearing at a maximal, you keep the child's quality of life at a maximal. On the same note, it's important for physicians to understand that when they treat kids with EB, not only does the ear canal have to be wide open, but we also have to be cognizant of speech, language development, and hearing. Some kids, once again with EB, can have hearing issues secondary to a lot of things, including ear infections. And so having hearing tests done on a semi-routine basis is reasonable. The other condition that we see often with kids with EB are blistering, crusting, erosions, and infections of the nose. And especially when some of the skin around the nasal opening, the nasal vestibule, becomes involved, it becomes a tricky problem to treat. Treatment is important because kids, babies, they breathe through their nose, and it's important to keep this part of their airway open so they can breathe comfortably, so that they can eat and drink comfortably. I don't know how many of you have tried drinking out of a bottle by pinching your nose. You can't do it. So keeping this nose wide open is really important. And so when these crusts build up, it's important to get this crust to come off gently without inducing any additional trauma to that nose. It's kind of a double-edged sword though, however. The more you play with this area, the more trauma you do induce. And the trickiest part is some of these kids will close down that nasal opening. That nasal vestibule will become scarred and closed. And in those situations, it's very hard to treat or open them up surgically. And it creates a bigger problem the more aggressive you are at cleaning this out. So it is a little bit of a double-edged sword. You want to keep those crusts out, but at the same time, you don't want to induce any additional trauma. Kids with EB can also have the normal run-of-the-mill problems such as allergies, chronic sinusitis, and a dry nose. Most of the, I live in the Midwest, most of our heaters are on all winter long, and kids with dry noses are a very common phenomenon. So all of these are routine problems and can apply to kids with EB as well. And taking care of these, either with allergy medicines, antibiotic, moisturizers, nasal mist, nasal saline irrigations, are all very reasonable things. Increasing the amount of moisture, especially when the heaters are on at home, is also a nice benefit. Emollients and moisturizers to that nasal opening can help decrease the amount of crusting. But it is somewhat of a tricky situation. Kids with EB also have blistering of their mouth, and I think you guys are more familiar with this than I am. And this is a hard thing to see as it decreases their ability to eat and enjoy foods. One of the things that's helpful is something called magic mouthwash. I don't know how many of you have heard of this, but there's a lot of different formulations, but essentially it's a mixture of Maalox, Benadryl, and lidocaine. And a lot of physicians use this, and if you ask your pediatrician or your family doctor, they can come up with this recipe, the pharmacies will make them, and it is helpful, especially when there's the acute onset of some of these ulceration. The kids swish it around in their mouth, they spit it out, it leaves a small coating on their mouth, which helps relieve some of the symptoms of discomfort and pain. Kids with EB get chronic recurrent tonsillitis. They get strep throats. In fact, sometimes kids who have chronic strep infections of their skin wounds on their body, sometimes this is related to being a strep carrier. In our practice, in our EB clinic, when we see kids with chronic recurrent sore throats, strep positive, and also an association with wounds that culture positive for strep, we often recommend an adenotonsillectomy. A lot of ENT doctors, a lot of physicians are a little hesitant to consider an adenotonsillectomy in a child with EB because they're afraid of adverse scarring and also just the trauma of anesthesia and intubation. These are all very reasonable concerns, but an adenotonsillectomy in some of these kids can be done very carefully and with minimal sequela and actually quite a bit of benefit, not only to their recurrent sore throats, but also to their wounds. And so it's important to discuss this with your physician as well, see if your child's a candidate for it, if they're having recurrent strep throats and recurrent strep wound infections, and to see if the physician feels comfortable doing an adenotonsillectomy. One of the toughest problems that I deal with kids with EB as an ENT doctor is when the disease process involves the airway, specifically around the vocal cords, around the larynx. Now the skin lining the outside of the nose itself, down into back of the throat, down to the vocal cords, is all very similar to the skin on the outside of the body. And so it responds in a lot of kids to trauma or to shear forces the same way as the outside skin does. And so kids can have involvement of their airway. Kids with EB can have involvement of their airway. And it will present often with hoarseness of the voice, trouble breathing, and even feeding difficulties. There was a large registry done of kids with EB a while back, and it was one of the first studies that actually looked at how common airway involvement is. And what they saw was that kids, especially with junctional EB, were at the highest risk for airway involvement. Kids with dystrophic EB were at a much lower risk, though they had some, and kids with simplex were at the least amount of risk for airway involvement. And I'll show you what I mean by this. I wanted to go through some slides of what a normal airway looks like. And so this is a cartoon on the left panel of this slide showing the nasal airway up here, the oral airway down here, and what we're talking about is involvement in some kids of this area, the larynx. And so if you look at that with an endoscopy, so this is a camera coming through the mouth looking at the larynx, what you'll see is the epiglottis, a flap-like piece of tissue that protects the larynx, the vocal cords, and the vocal cords up closer, and below the vocal cords and into the trachea, going down into the lungs. So the skin of the larynx and the vocal cords is very similar to the skin on the outside of the body, and will respond to trauma the same way the outside of the body responds to trauma with wounds. But as soon as you get to the underside of the vocal cords, the skin changes, the skin lining of this airway changes and is a lot more resilient to trauma. And so you don't see a lot of involvement of the airway below the vocal cords down into the lungs with EB. This is a endoscopy showing what a normal airway looks like. Once again, coming down to the epiglottis, the larynx, and going through the larynx at a point, looking at the rest of the airway. Now, when children are intubated for surgery, when the endotracheal tube goes either through the mouth or through the nose, it goes into the airway through the vocal cords, into the trachea. And in all kids, the points of maximal friction are either at the nose if you do a nasotracheal intubation, in the mouth where you, or if you do an orotracheal intubation, and then especially on the vocal cords where the endotracheal tube goes through these vocal cords. So I bring this up because a lot of the kids that have airway issues are ones who have undergone previous surgeries. And this brings up a topic as well. If any of your children do undergo surgery, it's important to speak to the anesthesiologist and the rest of the operative staff about the precautions. Typically, in our operating room, we use special tape, special ways of securing the endotracheal tube. We lubricate all our hands and instruments, that anything that touches a child causes a minimal amount of friction, so to minimize damage. We also make sure that the endotracheal tubes are of the right size or a size smaller than appropriate for that size child, so that we minimize the frictional forces as well. Most facilities that deal with children with EB are going to be comfortable with this, but it's worthwhile asking those questions. So what are the symptoms of some of the of airway involvement? I mentioned a few already. Hoarse quality of the voice, getting winded or feeling out of breath very easily, noisy breathing, especially on inspiration, so you breathe in and it sounds noisy. Increased frequency of choking on secretion and swallowing difficulties. So kind of the most general and common symptoms associated with airway involvement. If you see some of those, it's worthwhile talking to your physicians. I showed you what a normal airway looks like. I wanted to show you what an airway with a child with EB looks like. And so the thin epiglottis all of a sudden has become a lot thicker. The vocal cords are a lot more edematous. I'm trying to get down to the vocal cords in this child. Everything's just a lot more swollen. This is the same child after we put them on a little bit of reflux medication, specifically something like Prevacid. There are a lot of other brands out there, and things got a lot better. I show you these slides to point out two things. One of them is that these kids with EB can have, dystrophic kids with EB can have airway involvement, and this is kind of the typical appearance. But also the fact that a lot of these kids, because of swelling problems, have a lot of secretions. They keep a lot of secretions in the back of their throat. They also have a lot of swelling of their larynx, presumably because of reflux disease. When we see kids with airway involvement, one of the first things we do is put them on reflux medications. It's a very benign treatment, and if there is an insult from acid coming up from the stomach, it minimizes the acidity and the injury to the larynx, and it seems to be helpful in many of these kids. And this is just a couple of more pictures to show you how that looked. 1 and 2 are the same kids treated with reflux medication only, and you can see that the swelling has gotten a little bit better. And similarly, over time, things continue to get better. I mentioned that there are 2 different types of reflux medication. One of them is something called H2 blockers. Those are Zantac and Pepcid, and a few others. They're some of the weaker drugs for acid reflux. The proton pump inhibitors, things like Prevacid, Nexium, Protonix, and there are a few others, are the stronger drugs, and this is what I usually start our kids on. Some of the kids with EB have minor problems with their airways that can be fixable surgically. And there's been a big hesitancy among physicians to treat them because of the fear of adverse sequelae, specifically additional scarring. This is a paper that we looked at a few kids, and specifically a few kids who had junctional EB with small airway issues. They had, you experience problems with your child's airway. Assessment is important. Reflux medications are possibly beneficial with low risks and morbidity. And then if there is a surgical treatment that is small and minimally invasive, it might be worthwhile considering.